Thank you, Chris, for the vision statement from Rotary International. And it is my pleasure to welcome John Lumpkin, Dr. John Lumpkin, to our meeting today as our speaker. He is, since April 2019, since April 2019, he's been the president of the Blue Cross Blue Shield of North Carolina Foundation. And he's also the vice president of Drivers of Health Strategy for Blue Cross and Blue Shield of North Carolina. Dr. Lumpkin also serves currently on the board of directors for the Foundation for Food and Agriculture Research and as chair of the Digital Bridge, which is a multi-sector forum to collaborate on solutions for a nationally consistent and sustainable approach to using electric health data. I think that's going to be big. So thank you so much for your efforts there, Dr. Lumpkin. Most recently, he served as Senior Vice President, Programs for the Robert Wood Johnson Foundation. And before joining the foundation in 2003, he served as Director of the Illinois Department of Health for 12 years. Dr. Lumpkin is a member of the National Academy of Science and a fellow of the American Academy of Nursing, American College of Emergency Medicine, Emergency Physicians, and the American College of Medical Informatics. His many distinctions and honors include the MacArthur McCormick Excellence and Dedication in Public Service Award, Public Health Award from the Association of the State and Territorial Health Officials, as well as the Jonas Salk Health Leadership Award. He earned his MD and BMS degrees from Northwestern University Medical School and his MPH from the University of Illinois School of Public Health. Dr. Lumpkin was also the first African-American trained in emergency medicine in our country after completing his residency at the University of Chicago. Please help me give a warm welcome to Dr. John Lumpkin.
Thank you. Thank you. I'm going to share my screen if the host can give me permission.
Oh dear. I thought I had done that. So what do I
Make him a co-host, Mary. That should help.
Okay, how do I do that, Marie?
Go to the participants, right click on more. There should be a choice.
Okay. I think my thing, I don't know why. I am so sorry. The only thing I am getting on that is when I click on participants, right? Maybe I'll just see if I can do for him.
Mary, if you go and take your mouse or pointer over his name and his rectangle where the three dots are, do you get anything there that you could move him?
Well, I can make him I make him a host, which
Yes.
means that I'm no
Yes.
longer. So, okay, we'll go
Yeah.
with that then.
Yeah.
I was looking for co-host.
No.
So you are now the host, John. You may.
Great.
My apologies. Woohoo.
Great. Thank you. And it's a pleasure to be here and to talk about an issue that's really important in our nation and certainly important to me. And that's the impact of racism on health. We all know that this is the age of COVID and that there are certain risk factors associated with that. Those are age, chronic illness, obesity, diabetes, lung disease, and kidney or liver disease. But COVID has also highlighted the vulnerabilities that have accumulated as a result of rising obesity and the resultant chronic disease. What we see with COVID is that we have a significant racial disparity that exists on those who have suffered under the disease. And we see that Black people, for instance, have a risk of significant outcome from COVID that's twice that of whites in this nation. This reflects some of the differential impact we see of mortality, not only for COVID, but also of all diseases in this nation, where we see nearly a 20% increase in all-cause mortality for Blacks when compared to whites. Life expectancy is frequently tied to education, but even with education, the Black and white differential does not go away. In fact, it gets worse. So the question is, what is going on here? When we look at the differential, where as Black people become more educated, the differential between Blacks and whites has increased. Well, first of all, I think it's important to talk about terms and note that when we talk about race, that this is not a biological descriptor. And in fact, is a sociological one. It's a social description, as was noted by the Human Genome Project. But what does that mean? Well, when we think about that and look at human variation, the majority of human genetic variation exists within racial groups and not between them. So what does that mean? Well, to do that, I need to talk a little bit about some of the human genome and some of the topics. And one of those is SNPs, or SNPs, or single nucleotide polymorphisms. These are the differences in the human genome from one person to another. There was a recent article that identified that there were 8 of these single nucleotide polymorphisms that are associated with skin color. Other data shows that it may be as many as 100. But we put that in the context of the fact that there are more than 350 million different variations in the human genome. That when we look at just those associated with race, they pale on the differences that we've seen between people. So the differences are not in our biological makeup, but in the way that we live and the choices that we have. As my former boss once said at the Robert Wood Johnson Foundation, that the choices people make are determined by the choices they have.
Right.
Mm-hmm.
And positive choices for people, those good and healthy choices, are frequently and most likely determined by their communities. And often, the choice to be healthy becomes a difficult choice. If we're going to build our community to support health, we need to build communities that make health the easy choice. Because without that, people are often forced to make life-altering decisions between housing, transportation, healthcare, or food. And all too often, when it comes down to the end of the month, because the car is broken down and you need a home repair, or there's an unexpected health cost, food is where the choices are made to skimp. And this leads to food insecurity and certainly has a dramatic impact. But when we look at food insecurity and then make a comparison based upon whether or not they have health insurance, it becomes clear when we do this analysis. And in this chart, every single dot is a county in North Carolina. So it's percent of food insecurity in a county versus the number of people in that county under 65 without health insurance. So when we look at people in North Carolina across the country from McKinsey data, about 30% of employees with employer health insurance earn less than $30,000. And of those, 50% of households making 30% or less are food insecure. So then when we look at economic resources as a link to food insecurity, we find a stronger correlation. But when we take it together and think about it in a different way and begin to look at the counties looking at the percentage of people who live in there who are African American and correlate that with food insecurity, we see a very strong correlation. But I just got finished saying that race is not a biological construct. Science clearly shows that racial differences are not biological, but they are in fact due to other factors. They relate to how people spend their time. By and large, every year, except for leap year, there's roughly 500,000 minutes in a year. And of those, people spend about 120,000 working, 93,000 watching TV, 27,000 watching, eating and drinking, 15,000 shopping, 7,000 exercising, but only on average, for the average person in this country, 60 minutes are spent in a clinical setting. So health happens where we live, learn, work, and play. And it's in these places where decisions are made that impact health. James Baldwin said that not everything that is faced can be changed, but nothing can be changed until it is faced. And the events of last year with COVID and the murder of George Floyd have taught us nothing. It has taught us that we must confront the impact of race in our society and its impact upon health. So if you are Black living in this country, the realities have been clear as we've had a different life experience. All of us remember that Crispus Attucks was the first person killed in the American Revolution, very near Faneuil Hall in Boston. Yet the cultural experience of Black Americans can be better summed up by this Pulitzer Prize winning photo taken 200 years later, when a Black bystander who was on his way to a meeting at one of the official buildings was attacked during a demonstration against school desegregation. The contrast that 200 years makes. So yet Black Americans are not the only ones who have suffered under race-based policies in this country. In the 1830s, thousands of American Indians were forced off their land to make the way for white farmers. In this trail of tears, American Indians were forced from their homes on very short notice, often with just what they could carry, and forced marched to Oklahoma. Nearly 60,000 were removed by federal troops, improperly clothed and poorly fed. And almost 13,000 died on the way. This is just one of many assaults of the first people as a national program assaulting their culture and their very lives was instituted throughout our history as a nation. For those who are of Hispanic heritage, there was a period in 1919 when mobs attacked and murdered African Americans in dozens of cities across the country. But historians note that this was also an issue for Latinos and Mexican Americans. In towns and villages in the cities in the West, Mexican Americans were subject to torture, lynchings, and other violence at the hand of white mobs and law enforcement agencies such as the Texas Rangers. Historians say that from the period of 1910 to 1920, an estimated 5,000 people of Mexican descent were killed or vanished in the US. Just over 100 years after the formation just 100 years after the end of the Civil War, during the Second World War, a similar pattern of forced removal and internment by US government soldiers occurred. In this case, it was the Japanese living on the West Coast. They were forced to move quickly, and their property was liquidated, most oftenly to white purchasers. They were placed in internment camps behind barbed wire and guarded by US soldiers. Mass internment of 120,000 Japanese, most of who were US citizens. And this is compared versus 11,000 individually vetted people of German heritage who are living in the United States. We have a significant history. However, because of the data is better and my own particular interest, I'm mostly going to focus in on the issue of racism and Black Americans and its connection to health in this country. We see these disparities nationally, and we also see them in North Carolina, where Black babies die at 2.4 times the rate of white babies, and that we see higher rates of kidney diseases related to deaths, as well as mortality due to diabetes. And there are many other disparities that we see across our state. As Martin Luther King said, of all the forms of inequity, injustice in health is the most shocking and the most inhumane. So after the civil rights movement, we've seen some impact, but not dramatically so. As Don Berwick said, every system is perfectly designed to get the results that it gets. What is the system that we have in our country that leads to these results? In this country, that system is racism, and specifically structural racism. It's the interplay between education, schools, housing, finance, and healthcare, and the way all of these factors interact among themselves that lead to the differences that we see in outcomes and the health of people of color in this country. Structural racism, as defined by the North Carolina Institute of Medicine, Healthy North Carolina 2030 report, has identified structural racism as the policies, institutional practices, cultural representations, and social norms that lead to the disparate outcomes that we see in our state. So let me talk about how this looks and start off with public policies and institutional practices. Sampson and Wilson had a pivotal study in 1995 that found that the living conditions for Blacks and whites varied dramatically. They found that in the largest 171 cities, that there was not even one city where whites lived in conditions equal to those of Blacks. And in fact, the worst urban context where whites reside was better than the average context for Blacks. And what was true then, 25 years ago, remains true today and has its roots that go back centuries. So when we look at our state and the patterns that existed of where enslaved peoples were at in 1860, and what has changed? Since the end of the Civil War, policies at the federal and state level, including the National Housing Act of 1934, the Federal Housing Administration, the Federal Home Loan Board, and Homeowners Loan Corporation, have had an impact upon Black people and their lives and their ability to be successful. When we look at now in 2017, the percentage of people living in communities across our state, we see that there's a strong correlation between those same communities that had the largest number of enslaved peoples in 1860. And then when we go further and look at the tier arrangement that we have in North Carolina through the North Carolina Department of Commerce, they tier the counties based upon economic disadvantage. Tier 1 being those that are most economically disadvantaged, and Tier 3 being those that are the most affluent. And the same portion of our state that had the largest number of enslaved people in 1860, which has the highest percentage of people of color today, are also the ones that are most economically disadvantaged. We can see this kind of pattern by looking at the impacts of federal redlining policy in Greensboro. In 1936, these federal policies determined which communities were the best ones to invest in as part of the home loan program, and which ones were those that should be avoided. As a result, these areas in Greensboro were the ones that were redlined. In other words, on the maps, they were circled in red. These are areas with no homeowners loans, therefore no home ownership, and no accumulation of wealth from generation to generation. Some 86 odd years later, when you look at Greensboro on a map, and these areas here are areas that are areas with low home value and low income, are exactly the same areas that were redlined in the 1930s. And these are the same areas that today are areas of high racial or ethnically concentrated areas of poverty. So it's no surprise at the NCIOM report that when we look at a comparison of the number of people of color, of Black people who are living in poverty, that they are significantly higher than that of the white population. However, this has an impact not only about people who are living there today, but on their children and their opportunities as they move forward. Poverty has a dramatic impact upon children and their ability to be successful in life. So when you look at SAT scores and you do a comparison of family income to average SAT scores, you can see that there's a 400% range between the highest band of income and the lowest. And that's the difference between going to a community college and going to Harvard or Yale. But the legacy of redlining is even greater than just the impact upon income. Black households with incomes of $50,000 and $60,000 between those areas live in communities that are more likely to be polluted than white households with incomes below $10,000. In other words, people of color, Black people who live in redline communities, poorer communities across the country, are more likely to be exposed to polluted air. Redline Black communities tend to have 5 to 13 degrees average higher temperatures. And this is many times attributed to deforestation that occurs as communities are blighted and other factors. But when you put it all together, women who are exposed to higher temperatures and air pollution are more likely to have premature, underweight, or stillborn babies. The legacy of redlining has a great impact upon children being born today. And health exposures associated with the impact of redlining, more than 9 million people of color living near hazardous waste sites. More than 9 million people living near hazardous waste sites are people of color. 6.5 million African American residents live in areas with higher than average exposure and pollution. And Black Americans are 3 times more likely to die from exposure to air pollution. And when you look at COVID, there are higher COVID rates in areas with high fine particulate matter pollution. And so the historic patterns begin to add up and have impact today upon the health of people in our state. In addition to the public policies and institutional practices, these are also represented in laws. And let me give an example of one particular aspect of this. I'll talk about incarceration rates. In North Carolina, Black people represent 22% of the population, but over half of the people who are incarcerated. Does this respond to how they act, or is this an issue of historical practices? Well, let me show how laws have impacted that and the implementation of laws. And that is in regards to the National War on Drugs. The war on drugs began in 1971 under the administration of Richard Nixon. And let's look at the impact of this program 50 years later. First, we need to look at data to correct the misconception about who uses drugs and engages in the drug trade. And this is based upon data from the Census Bureau and other federal sources. On average, Black people in this country use drugs at a lower rate than the white population. And they're involved in the drug trade at a rate that's about the same. Yet when you look at rates of incarceration and arrest, drug rates for African Americans in this country are 3 times higher. Incarcerations are nearly 4 times higher at both the state and the federal level. So what about this is a war on drugs as opposed to a war on Black communities in our nation, using drugs as the excuse? Structural racism also includes cultural representations. There was a study that was done, published in the Journal of Sociology, where 2 Black and 2 white, young, well-groomed, well-spoken, college-educated men with identical resumes applied for 350 advertised entry-level jobs in Milwaukee. On each team, one said that they were a parolee, and one said they had served an 18-month sentence for cocaine possession. In some of those interviews, that person who said they had a record were white, and others that they were Black. When they totaled it all up, it was easier for a white male with a felony conviction to get a job than a Black male whose record was clean. And this study has been repeated a number of times since then with similar results. Part of this is because of the racial stereotypes that we have in our culture. There's a project called the Beagle Project. They looked at over 10 million words, looking at books, newspapers, magazine articles that the average college level student would read in their lifetime, and allowed us to assess how Americans have seen or heard words paired together over their lifeline. And other sociological studies show there's a strong correlation between how people view things and the correlation association of words in the literature to which they're exposed. For Blacks and whites in our society, there were strong correlations in words in the literature. For Blacks, it was being poor, violent, lazy, dangerous, ignorant. For whites, it was wealthy, successful, educated, and ethical. And it is these concepts which are built into what we read, what we see, and what is part of the milieu that our children growing up see, creates this various images of individuals. And as a result, these kinds of views, this leads to discrimination, defined as those who get less courtesy, less respect, poorer service, considered dishonest, called names, threatened, or harassed. Many of us grew up saying sticks and stones can break my bones, but names will never hurt us. But that's not really true. There was a study that was done looking at allostatic load, and in other words, the impact of chronic stress. They looked at 331 Black teenagers in rural counties in Georgia at the age of 16, 17, and 18. And they asked them how often they were exposed to discrimination. Those teenagers who reported high levels of discrimination were linked to individuals with higher allostatic load at age 20. In other words, they had elevated stress hormones, elevated blood pressure, and elevated body mass index, and more likely to be overweight and obese. Other studies have shown clear correlation to exposure and discrimination to coronary artery disease, blood pressure, lower birth weight, cognitive impairment, poor sleep, increased mortality, and obesity. And I just want to report that all of these, or suggest that all of these things are increased impact of chronic disease, obesity, diabetes, lung disease, kidney or liver disease, all of which, as I opened up, are associated with risk factors for COVID, severe COVID illness and death. Institutional practices and social norms also have an impact. In studies that have been done with adverse childhood experiences, there are clear differences in how the brain functions of young children, preschool children, when they're exposed to these adverse childhood experiences during this period of time in their life. And what are adverse childhood experiences? Family financial distress, a parent separated due to divorce or death or being sent to jail, hearing violence in the home or witnessing violence in the neighborhood, living with someone with mental illness or with substance use disorder, or treated or judged unfairly due to race and ethnicity. Yet when you look at this and recognize for the average Black child, because of high rates of poverty and because of high rates of discrimination, they already have 2 adverse childhood experiences just starting off to go. In North Carolina, Black children are twice as likely as white children to have 2 or more adverse childhood experiences. And this is significant because children with multiple adverse childhood experiences are more likely to have attention problems in the classroom, more likely to have social problems, and more likely to be seen as being aggressive and breaking rules. And this leads to them being less likely to be successful and having multiple academic problems, such as being unable to understand a story, or having below average math skills or below average reading skills. One would think that the logical approach to this in the school system would be to address children with these kinds of adverse childhood experiences with therapy and treatment. Instead, our school systems address these problems with suspensions and other exclusionary disciplines. Black children are excluded from K through 12 at a rate that's 4 times higher than white children. And while it's harder to measure preschool's exclusionary discipline, nationally, Black children are excluded at a rate that's more than twice that of white children in the preschool setting. And this means that by the time they enter kindergarten, these children are behind and stay behind the rest of their lives. Our Blue Cross North Carolina Foundation is having the issue of preschool suspensions as a major area of our work and looking to fully define this issue and to begin to find solutions. Because not all of this is in the statistics. Let me give an example of what we've seen, a story about a child whose parents did all the right things. They enrolled their child right after birth in one of the best preschools in Charlotte. And by the time he was 4, he had grown taller because his father was a tall man than most of the other kids. The teacher said to these 2 Black parents when he was 4, "I'm going to have to keep my eye on him because he's such a tall one." And this child was sent to the headmaster repeatedly for asking age-appropriate questions. Or when the headmaster wasn't available, he was sent to the cook, the only Black employee at this preschool. His parents removed him from the school, and he's doing much better at another institution. But this is a classic case of pushing children out of early learning spaces, adultifying and demonizing Black children, especially males, because of their size, and excluding families from the early education process. But we can do better. It doesn't have to be that way. Here in North Carolina and South Carolina, in a study that was based at University of North Carolina, there was a study that was called the ABC Darien Project. Economically disadvantaged children were randomized into safe and nurturing environments, provided good nutrition, pediatric care, and early childhood education. And that was the intervention. But what's unique about this study is they followed these young people as they grew older. At age 21, just with that preschool intervention, they had better scores, more educational attainment, less teen pregnancy, and less marijuana use, and fewer depressive symptoms. You know, Plato said that when equality is given to unequal things, the resultant will be unequal. These children in this study, when they were in their 30s, were more likely to have gotten a baccalaureate degree and also were less likely to have metabolic syndrome, to be overweight, or to have chronic disease, all with these simple interventions. That's why we talk a lot about equity as opposed to equality. Equality is giving everyone the same thing. I'm a physician. There is no physician in this state or in this nation who would say that the right treatment is to give everybody with diabetes the same dose of insulin. Yet frequently when we talk about policies and programs, we talk about giving everyone the same thing. Equity is providing the resources that people need to be successful. And we can see that this approach can have a dramatic effect. I talked about the ABC Dairying program, but there was another program by the National Housing and Urban Development called Moving to Opportunity. Here, individuals who were in communities with high rates of crime and high rates of poverty, their families were moved to other communities with lower poverty and lower rates of crime. The children who grew up in these new environments had higher incomes, higher lifetime earnings, were more likely to attend college, and less likely become single mothers. We know we can do policies here in this state. We know we can make policies here in our nation that gives everyone a fair opportunity to be as healthy as possible. But to do that, we have to address the health impact of racism, and it requires dismantling the barriers and changing the policies both inside and outside the healthcare system that lead to such inequitable results. Because we believe, both where I work at Blue Cross and at the Blue Cross Foundation, that is so critical for us. And therefore, our motto, which you see on my background, that we won't stop until healthcare is better for all. And at this point, I'd be happy to stop sharing and to hand it back and answer any questions.
I just want to comment that we've heard many of these concepts before, but you've put them together in a way that was very meaningful and interesting. And so thank you for your very informative presentation.
I would like to second that in that that's one of the most cogent presentations of the facts that I have seen and heard. Thank you for doing that. It really was very educational. And as I say, many of us already knew those factors, but the way you put it together was magnificent.
And
Amen.
Suzanne, I believe you have a question.
I do. I understand. I was just shocked that education level has no impact really on the high mortality for infant mortality to Black mothers and also to Black women's health. I was wondering if you had any suggestions of how we might really work toward improving those things. I just can't believe how terrible infant mortality and mother death is in North Carolina for both white and Black and Hispanic and other women, but particularly Black women.
So, you know, that is one of those startling truths that we need to address in multiple ways. And I will tell you that Blue Cross has made this one of its priorities of reducing Black maternal mortality, as well as addressing prenatal care and the other factors. I'm sure that many of you have heard the challenges that Serena Williams had when she
Yes.
was
Mhm,
Right.
giving
mhm.
delivery. This is where, the issue of implicit bias that exists within our healthcare system. And I just go back to the words of James Baldwin. You know, not everything that we face can be changed, but nothing can be changed until we face it. And that's the first step. We have to face the fact that these realities exist and then look for ways to change it. It has to do with access to prenatal care.
Right.
In prenatal care, there are many programs. There's one that our foundation has supported the development out in Nashville called Mothering Nashville. And a critical component of that is the development of doulas, but doulas who
Right.
were hired from the Black community and
Mhm.
trained. I saw this when I was in the state of Illinois, where we created a program where we had peer case managers hired from the same communities. People will listen to their neighbors. That helps rebuild some of the structures that exist. We need to just build and focus in on our communities becoming places that promote health. And this challenge, as well as many others, will begin to have a path forward to creating healthier communities.
And we have a member, unfortunately, she's not here today, Latasha, Latasha Rouse. And she, because of what she experienced with giving birth to her child, and just, it was not a good experience. She went ahead and developed a doula service here in Raleigh. Marie, do you remember the exact name? I don't have that in front of me.
Birth Sisters, I believe, and she
Yes.
gave birth to triplets, and it was a high-risk pregnancy.
Mhm.
And so after that, then it was, yes, Birth Sisters. And so doula services, and that's here in Wake County. So that is something that was recognized as a need. And so I guess a question that I have for you is, what are your thoughts on what we as a group,
Mhm.
Rotarians or people of action, we
Mhm.
try to see what we can do to make things better in our community. So are there some suggestions for a group like ours to be involved in the community? What do you see that we could do to help with these
Well,
issues that you've addressed?
yeah, I think there are multiple lines of engagement that people who are informed and right-minded in their communities can have an impact. And that is by working together on the policies to help make your community more equitable. We often talk about the health of the nation or the health of our state. They're all dependent upon the health of each individual community across
Right.
the state. To what extent is your community engaged in outreach to communities of color? Frequently, many of those are hidden because of the affluence, the overall affluence of the communities. But we know not too far away, there are communities of color. This has particularly hit the Hispanic community in North Carolina severely with COVID. But what are the policies of the municipal governments and the county governments? There are many programs that are federal programs that benefit people, have positive impact upon increased health and reduced healthcare costs. Let me just say one of them is how people are eligible for programs like SNAP, the Supplemental Nutritional Assistance Program, better known as food stamps. People are enrolled at the county level, and the way people are treated varies from county to county. What are your policies of your county government where you live on enrollment? Is it to do outreach and encourage people to sign up? to this federal program for which they're eligible? Or is it, oh, these are people who are trying to grift on the government? We in North Carolina have the unfortunate distinction of being one of 12 states in the nation that has not expanded Medicaid.
Right.
Mhm.
And think about what that has done because of the way the Supreme Court decided on the Affordable Care Act. People who earn 100% of poverty, so roughly $14,000 or $15,000, are eligible for insurance under the Affordable Care Act with almost a complete subsidy and support for out-of-pocket costs.
Mhm.
If you earn 99% of that, just let's say $14,000 for an individual, and you're working 2 or 3 jobs to do that, North Carolina as a state says you're not eligible for any health insurance whatsoever.
Yeah.
You make too much to be on Medicaid. In fact, childless adults are not eligible for Medicaid. And you don't make enough to be eligible for the Affordable Care Act. This is one of the cruelest sets of policies, and it's a policy that we set here in our state. So you know, I think
being an advocacy role, playing an advocacy role to support the institutions in our and people in our communities that are not they're not being made aware or how to facilitate them getting the services that they qualify for.
right. I think that's the issue. The other part is, you know, I'm a firm believer in universal pre-K.
Mhm.
You know, this again is another policy. It doesn't have to be a policy that's made in Raleigh. You know, there are things related to availability that can be done on the county or the municipal level. So no matter where you're at, focusing on pre-K is another one. Another one is school meals. Right now, we're in a hiatus because of the impact of COVID and the American Recovery Act, where now school meals are free for everyone. But what does it mean when you're the kid who grows up and goes to school and you're the one who's on the free meal?
Mhm.
You're stigmatized. There are kids who will go hungry before they will go in the line and get that free meal. Why not just have it, everybody gets the free meal?
Right.
You know, and there are counties in North Carolina that had already instituted that practice. So it can be done at the school district level, it can be done at the county level. And I can go on and on, but the point is having fair-minded people in their community, identifying the challenges and working together to overcome them at the policy level in the local communities is something I think the Rotarians can do and just have a huge impact.
Yeah, John, I want to just chime in first just to thank you very much for taking the time to talk to this group. In my experience, as many years in Rotary, this is an unusual approach that Rotary is using, not the e-club part of it, but the philosophy behind this particular club, which is why I'm here. I mean, at least several of us are members of other clubs, larger Rotary clubs. But I think it's important to work in the local communities. Rotary's really noted for a lot of things internationally and done some fantastic work with polio. But there's a lot of denial in this country that things are well or it's somebody else's fault. It's always somebody's fault.
Mhm.
And I think it's important that we do this. And you can see this on the literally when CNN is on and all the back and forth that goes on. So I really appreciate it. I am delighted to have, for those that don't know, Dr. Lumpkin and I have known each other professionally through as public health colleagues going back, I guess, more than a few years, John. I was surprised and really delighted when I found out that he was coming to North Carolina. I think the state really needs him. So just wanted to get that point in.
Thank you.
Charlie. We had one more question, but I think, Teresa, perhaps you could email your question to Dr. Lumpkin because it's 1 o'clock and we need to move on. And so I am going